Thank you very much indeed. Thank you, Diapers India. Thank you, the chairs and the committee, and particularly Bansi for giving me this honour. As you all know, Professor Sadiq was a great inspiration and a leader, and also a mentor to many of us, including I know Bansi. So it's even a double honour to have this award. These are my disclosures. So the next few minutes, I've been asked to go fast, so I will try and go as quick as I can to talk about the changing phenotype of our population, obesity as a driver for multiple long-term conditions, barriers to management, and potentially some solutions as well. In terms of the changing phenotype, we used to just talk about diabetes before, but now we know there are many interrelated complications, and we'll be listening to all of these over the next 3 to 4 days. We used to talk about diabetes and cardiovascular disease, and the kidney disease came in, and now we're talking about liver disease, and there's many more still to come over the years. And this is the kind of patients that many of us who are general practitioners in clinical practice. Simon's here, who's a fellow general practitioner, and we don't see just people with diabetes or particular conditions. We see anything that walks through the door. So an 80-year-old lady who comes in, they may have CKD, type 2 diabetes, heart disease, and heart failure. But when they go to specialist care, they're seen by one clinic, so one patient, one condition, while we tend to see them more holistically, looking after all of these conditions, because many of these, as you know, are interlinked. So there have been a lot of transitions in diabetes over the years. In the 60s and 80s, there was a low prevalence of diabetes. Then we had diabetes increasing, improving care. Type 2 diabetes in the youth started. Now the peak seems to have reached. In some countries, we're seeing a downward trend. Complications are improving. We'll talk about that in another presentation. But now we're seeing the emergence of multimorbidity, and I'll tell you a little bit about the term shortly. Because there's been declining in mortality, diversification of the morbidity, and increasing conditions as we live longer. Multimorbidity is a term that we don't like to use in the UK because patients say we are not multimorbid, we are not morbid. So the term in the UK that people tend to use, it's a mouthful, but multiple long-term conditions, or MLTC for short, which is co-occurrence of at least 2 chronic conditions in the same individual. Similar to an extent to comorbidity, where we say combined effects of an additional condition in reference to the index conditions, such as diabetes. Then if you get stroke, that's a comorbidity. These are the conditions that are often talked about when we talk about multiple long-term conditions. This is a systematic review we conducted of 566 studies. And if you look at the detail, the commonest chronic conditions seem to be cardiovascular, metabolic, respiratory, musculoskeletal, mental health, and cancer. And mental health is playing a major role in people with multiple long-term conditions, but we don't have a high prevalence unless we measure it, which isn't done routinely in clinical practice. The mechanisms driving it, obesity certainly is one of the mechanisms, and some of the related pathophysiological mechanisms are related to obesity, such as inflammation, insulin resistance. There's a good work coming in terms of telomere length, showing that it's associated with multiple long-term conditions. You see there's a number of conditions, over 200 conditions are used to describe multiple long-term conditions, which really isn't very useful. So again, we've done a Delphi recently to show that we should be talking mainly about 35 conditions when we talk about multiple long-term conditions rather than 200. And I'll talk about the challenges at the end. This is the largest data for multiple long-term conditions. We looked at the whole population of England. And what you see is, first of all, with age, there's increasing on the left top-hand corner, increasing multiple long-term conditions. And we may think that multiple long-term conditions increase from the age of 60. Well, as you can see here, 2 or more conditions seem to increase from a very, very young age. Even teenagers get multiple long-term conditions, but obviously the steep rises are from the age of around 30 to 40. There's no difference in sex. If you look at deprivation at any point of age, deprived populations usually have twice the prevalence of multiple long-term conditions compared to people who are not as deprived, which is what at the bottom. And for the first time, we're showing very convincingly that ethnic minorities, South Asians and Black populations, tend to get more multiple long-term conditions, and usually at a younger age as well, which we know, for example, in diabetes, white populations get it at the age of 60, South Asians like us get it at the age of 48, 12 years earlier. And that's why we'll be accumulating multiple long-term conditions at a younger age as well. Multiple long-term conditions, as I said, is not just in the 60s and 70s, and these are the conditions, the 5 most frequent conditions that we see by 10-year age bands, and this is again from the same 60 million patient study. Initially, in the early years, we see conditions like asthma, epilepsy, autism, and then as you start going into the 50s, we start seeing diabetes appearing, 40s and 50s, and now we're seeing a lot more young type 2 diabetes, and I know there's a really great studies going on in India in young type 2 as well. And then after the age of around 60, you start seeing more of the cardiometabolic conditions appearing. This is the worrying fact about multiple long-term conditions, that these are data from Liverpool looking at the aging population. In 2010, an average person used to live about 81 years, around 47 years without any illness, 23 years in some illness, and 10 years in major illness. In 2019, the data showed that we were living about a year more, but we were living in poorer health for longer, 25 years with some illness and 11 years with major illness. And the predictions are that by 2014, the UK will live to around 83 to 84 years, but again, living in poorer health. So we're doing everything possible to prevent diseases or manage disease, making people live longer. However, people living longer, but in poorer health. This is one way to look at long-term conditions, and this is for diabetes. Again, we looked at this for the whole of England data set as pairs of conditions. So these are various conditions. I'm not going into detail. At the top is dementia, at the bottom is serious mental illness. And what this does is the average onset of the condition in people with diabetes, that's in the red, compared to the people in the blue, which are the population level without diabetes. So on average, a person age of onset learning disability will occur with diabetes at the age of around 60. And then it tells you how many less years you live as well. On the left-hand side is women, on the right-hand side is men. So you have a number of years of life lost when you have 2 conditions, if you have diabetes and another condition. In terms of heart failure, atrial fibrillation, coronary heart disease, hypertension, the cardiometabolic conditions, they occur at the same age for men and women. However, women tend to live a little longer compared to men. And it's nice and easy to talk about pairs of conditions, but what happens in terms of mortality risk when you have more than one condition? So this was really well demonstrated in the Emerging Risk Factor Collaboration study. And what we see here is a reference at the bottom of someone who doesn't have diabetes, stroke, or a heart attack. So compared to someone who doesn't have any of those 3, if you have one of those 3, your risk of mortality is increased 2-fold. If you have 2 of those conditions, diabetes and MI cardiac infarction, or diabetes and stroke, or stroke and MI, your risk of mortality is increased by about 3 to 4-fold. And if you are unlucky enough to have all 3 of them, like my father was, diabetes, stroke, and an MI, your risk of mortality is increased 7-fold. So this is relative increases, but what does it mean in real terms for that patient? Well, in real terms, if you compare someone who doesn't have any of those conditions, no diabetes, no heart attack, no kidney disease, at the age of 60, someone with diabetes will live 6 years less. They've got 6 years of life lost. If they have diabetes and cardiovascular disease at the age of 60 compared to someone who doesn't have those, they will live 12 years less. Kidney disease, if you have early kidney disease, you will live 60 years less at the age of 60 compared to someone who doesn't have any of those. So that tells you in real terms the years of life you will lose if you have these conditions. That was the emerging risk factors. So we looked at this to put depression. It said mental health is playing a greater role in multiple long-term conditions. So here we looked at diabetes, cardiovascular disease, and depression. And as you can see, if you have all three of those, diabetes, one of the cardiovascular diseases, or depression, at the age of 45, you lose 9 years of your health, and 9 years of your life. At the age of 75, you lose about 6 years of your life. And if you just have depression, you lose about 1 year of your life at the age of 45. But the quality of life that person is very, very poor. So you can look at it this way when you add additional conditions as well. One of the major drivers for multiple long-term conditions is obesity. So we're famous in Leicester for obesity. This is Daniel Lambert, one of our famous residents of Leicester City. He was born in Leicester. He was 6 men of a normal size at the time. His waistcoat is still in a museum in Leicester, if you're ever visiting Leicester. Weighed 335 kilograms, and his height was less than 6 foot. And poor chap died at the age of 39. And he was sadly used in circuses, and people had to pay to see him, and had a miserable life. But the evolution of body mass index has been historically since 1835 by Quetelet, and it gained prominence in the 20th century. And it was the insurance industry that really fought onto this to say high BMI is not good for your health. And this was in as early as 1904, and they showed that body fat that was located around the waist was hazardous to health, as was excess weight. If you look at obesity, it's associated with a number of multiple long-term conditions. I've just given a few here that we talk about regularly, but over 200 conditions are associated with obesity, and most of these you are aware of. So just to give you, again, some data regarding associations of BMI with incident cardiometabolic multiple long-term conditions, so developing multiple long-term conditions if your baseline BMI is at a certain stage. So this is comparing someone who has a normal BMI, 20 to 25. Someone who has obese has about a 2-fold increase association with developing multiple long-term conditions. If you have a BMI of 30 to 35, about a 4-fold increase association. And if your BMI is more than 35, then about 14-fold increase association with developing other conditions in the longer term. In terms of overweight and obesity, also increases the risk of cardiovascular diseases without any metabolic conditions. And here again, where you see the association seems to be stronger with coronary heart disease for overweight and obesity, for cerebrovascular disease mainly for obesity, and for heart failure mainly for obesity as well. What about the barriers? Well, there's lots of barriers in managing. I'll give you a few examples, but there's fragmentation of health when you have multiple long-term conditions. There's limited resources for the healthcare system, but also for that person. For example, if there's out-of-pocket payment in countries like India, there's workforce issues because people are trained to look after one condition at a time. Sustainability of a healthcare organization is also compromised. There are geographic barriers depending on where you live and the specialties that you can get access to. There's socioeconomic factors, there's health literacy, there's digital divide, patient adherence, which I'll talk about, and many other behavioral change aspects that are difficult for that person. The other problem is there are no guidelines for multiple long-term conditions. They have been tried but failed. So, for example, diabetes will have a diabetes guideline. There'll be a cardiovascular guideline. So single disease, single guideline. Doesn't really help us to manage people with multiple long-term conditions. Some of the problems we have is the healthcare access for people with multiple long-term conditions because they keep coming regularly and often. So this is data from the UK CPRD we looked at. On average, a person without other conditions, just diabetes, which is probably about 17% of people. On average, 17% of people with diabetes don't have other conditions. 83% will have other conditions. If you're aged over 65, you will have diabetes and 5 other conditions. If you're aged under 65, you will have diabetes and other conditions. If you have no other conditions, just diabetes, they come to see the general practitioner in the UK about 10 times a year. If they have one condition plus diabetes, they come about 13 times. If they have 3 or more conditions with diabetes, they come 19 times a year to see the nurse or the GP in a general practice, which is just not sustainable when there's a free service. They also don't get the treatment. There's a delay in treatment because their patients are so complex. We have 10, 15-minute appointments, and we're not able to manage these patients adequately. So again, if they have cardiovascular disease or non-cardiovascular disease, more than one condition, 2 or more conditions, they're less likely to be offered the next therapy, second or third therapy, as appropriately as we should be doing if the HbA1c is high. Adherence is very difficult to measure, as you all know. The best way to do this is by doing urine objective assays using LCMS methodology. And Pankaj Gupta from Mumbai, who works with us in Leicester, is one of the pioneers of this methodology. And we looked at this on 200 adults with type 2 diabetes, and overall adherence rates were about 30%. They can measure about 80 metabolites in a urine sample, 80 different drugs on a urine sample, one urine sample. Here we just looked at the diabetes medications. As you can see, overall adherence was good for metformin, around 95% or so, but poor for sulfonylureas, poor for GLP-1s, and really poor for statins, which has been shown previously as well. But for ACE inhibitors, ARBs, calcium channel blockers, beta blockers, and for diuretics, it was over 80%, which is reasonable. And we found that people who were non-adherent, their HbA1cs, albumin-creatinine ratios, and lipid profiles were significantly higher compared to those who were adherent. So what are the potential solutions? Well, there's lots of solutions that are available, haven't been tested well in people with multiple long-term conditions. We don't have a good quality randomized controlled trials in these populations. System redesign has been tested in some areas. Care coordination certainly helps. A couple of really good papers from North America of someone with depression, cardiovascular disease, and diabetes having care coordination and improved outcomes. Self-management education programs, therapeutic interventions, and now we've got some great organ protective therapies, and then lifestyle interventions. But whatever method we use, we know that if we increase weight, there is increased association with condition. If we lose weight, there's a reduced association with other conditions. So this is data we looked at, again, a large database study looking at sleep apnea, type 2 diabetes, hypertension, dyslipidemia, polycystic ovarian syndrome, asthma, osteoarthritis, heart failure, venous thromboembolism, atrial fibrillation, CKD, angina, and depression. And you can see above 0 is increases in weight, 10 to 20%. Gray is the reference line of no weight change. And as you increase weight, many of these conditions in a linear fashion increase, and a linear fashion with 10 to 20% weight loss, you see them decrease in terms of association of accumulating those conditions. We didn't see any association of improvements of unstable angina or depression with increasing or decreasing weight. These are the options, and you'll be hearing about them, and I've seen many of the really great programs here about low-calorie diets, exercise, GLP-1 receptor analogs, and bariatric surgery. All are options for managing obesity. Reaching ideal cardiovascular goal, obviously, we need to try and have this mantra about physical activity, healthy diets, improving body mass index. Sleep is becoming more and more important for managing people. 7 hours seems to be the sweet spot, which unfortunately I don't get. Nicotine exposure, lipids, glucose, and blood pressure. We know that if you have ideal risk factor control for all of these and have chronic conditions, then usually your years of life lost will be minimal. Physical activity, we've talked about earlier today, very important. This is data from the English population of aging. We looked at over a 10-year period. If you are already physically active, then your accumulation of multiple long-term conditions is much, much less. If you're not as active, your accumulation is much higher. You start at a baseline which is high. As you can see, 50% had multiple long-term conditions, which increases to 60% within 10 years. And again, this is working with Tom Yates and Yogini in our group. We've looked at the life years gained. And again, this is modeling. So if you are physically active at the age of 45 and you have multiple long-term conditions, you have 3 years of life years gained. If you don't have multiple long-term conditions, you still have 2 years of life years gained at the age of 45. So physical activity, very, very important. There's SGLT2 inhibitors. This is Seto from our group, and this is the latest systematic review of 20 randomized controlled trials. We see improvement in microvascular outcomes, macrovascular outcomes, particularly end-stage kidney disease, but as you can see, improvements in nearly all the outcomes, microvascular outcomes as well. So these organ protective therapies we know do help in preventing other long-term conditions coming on. And if you look at combined macro and microvascular outcomes, you get reductions of around 25%. Similarly, from the same study looking at GLP-1 receptor agonists, again, we see improvements in macrovascular outcome, 3-point MACE, 15% relative risk reduction. Improvement in microvascular outcomes, again, around 14% relative risk reduction, particularly driven by renal outcomes. The other thing we need to think about is quaternary prevention. We need to stop therapies when it's right to do so. People get old, they get frail, but they're still on antihypertensive therapies, they're still on glucose-lowering therapies, and we need to start thinking about stopping these therapies because they're not going to be beneficial, then they may be harmful. And this is Sam Seydoux from our group looked at a systematic review saying there's only 10 studies you can safely stop therapies without causing any harm to patients. Finally, we need to think about new models of care. Patients like continuity of care. They want their care to be in primary care. They want, in the UK particularly, they want nurses with the skills, and they want longer appointments. And this is a model of care that we need to think about. Someone with multiple long-term conditions who's managed in a primary care setting with the specialist, with the pharmacist. We employ a lot of pharmacists in our practice now who look after long-term conditions. I hardly ever see people with diabetes unless they're complex. They're looked after by our pharmacists and by our nurses. But then we have access to our cardiologists, to our nephrologists and psychologists when we need to. And many of these we do now remote consultations with them, so patients don't have to go into hospital to see the consultants. So in summary, multiple long-term conditions will be the norm for people because we are living longer. Cardiometabolic conditions are the primary cause for morbidity and mortality in adults with multiple long-term conditions. And multiple long-term conditions contribute hugely to health inequalities and the inverse care law. We need to learn how to support people with multiple long-term conditions, and really the studies are not there yet. But it seems that a more multidisciplinary care models may be one way to go forward to improving outcomes for these people. Thank you very much for listening.